Welcome to this session, which will describe models of pediatric palliative care, including home and community-based programs. My name is Dr. Megan Doherty, and I'm a pediatric palliative care specialist in Ottawa, Canada. Our objectives for this session is that after you complete this video, you'll be able to describe how pediatric palliative care can be provided in home and community settings, and you'll understand the key considerations and challenges of this approach. Let's first consider how palliative care can be provided. We often think of palliative care as just the care provided by specialists who are at the top of this pyramid, but there's also general palliative care, which can be provided by all healthcare staff who have additional training in palliative care. And at the bottom of the pyramid is the most significant and important part, which is that palliative care is an approach to care. It focuses on child and family-centered care and quality of life. What does home-based palliative care really look like? It really focuses on the palliative care approach. We use trained community health workers to provide palliative care and to focus on quality of life for a patient and their families. The home care workers are generally supported by generalists in palliative care. These would be hospital-based staff who develop palliative care plans and support the home-based care teams. When starting a home-based care program, it's important to consider the goals of your program. You may want to consider, what do patients need the most? Some common things that you can usually provide early on include telephone advice about symptom management and guidance about what to do at the end of life, meaning in the last days or hours. You should also think about, what can your team potentially do? Can you provide telephone advice from a hospital-based palliative care team? Can you provide home-based symptom kits, which will help patients manage their symptoms at the end of life? And can you arrange or coordinate with community health workers to provide home visits supported by hospital staff? It's important to remember that children who can benefit from palliative care include children living with a progressive condition where there's ongoing deterioration of health or abilities, and children living with a life-threatening condition, or children who have significant pain or other symptoms which palliative care can address. Typically, in home-based palliative care programs, children with chronic neurological conditions are the most common. These include children with cerebral palsy and other brain injuries. Additionally, you may see children with congenital heart disease, genetic or metabolic conditions, often in situations where the exact diagnosis is not known. You may also have children with muscular dystrophies or conditions of muscle weakness, HIV/AIDS, thalassemia, hemophilia, and sickle cell disease. And children with cancer may be in home care-based programs, but typically only for end-of-life care. A home care team at minimum should have community health workers with some training in palliative care. Additionally, they need support and guidance from a nurse and doctor with some training in palliative care. And the supports are much improved with a psychologist or counselor and trained volunteers. Infrastructure-wise, the home care team needs a meeting point. They need some kind of storage facility, particularly for some controlled medications. They need some transportation and a home care kit, and communication abilities so that they can talk to the doctors and nurses who are providing them with additional support. This is generally done by mobile phone. Equipment contained in a home care kit should include medications, including morphine, midazolam, haloperidol, and hyoscine butylbromide. Morphine can be used for pain or dyspnea, midazolam as second line for dyspnea, for seizures, and for agitation, haloperidol for nausea, for agitation and delirium, and hyoscine butylbromide or some other secretion medication to manage secretions at end of life. Equipment in the kit should include at a minimum syringes and needles, a thermometer, and dressing supplies. Additional items can be added if there are more resources and depending on the skill level of the community health workers. The community health workers should also complete some form of documentation and have a home care file for each patient. And there should be a telephone log file so they can keep track of what calls were made and what was their response to the patient's concerns. This image on the right shows you a simple home care telephone log form which you can use, where the document can be just checked off for the different symptoms the patient may have and the response to the call, including whether there was any medication suggestions or other advice. This type of documentation makes it much easier for staff to complete the documentation, and then you can use this to review the documentation in future to learn about how the program's functioning and what are the common complaints that patients call with. Community-based palliative care services are a more advanced form of home care. The World Health Organization defines these services as including the involvement of the people in the community to address their own problems. And the community can be involved in all levels, from the assessment of the needs to planning and implementing the service, resource mobilization, day-to-day management, and evaluation of the program. In both home-based and community-based programs, community health workers are particularly important. These are typically members of the local community. They speak the language and understand the cultural considerations of the people they're serving, and they're trained in basic palliative care. They can have clinical roles, including providing basic clinical care through home visits, participating in the following activities typically: bathing, feeding, stretching and range of motion exercises, reminding and supporting patients to take their medicines as the doctors and nurses have advised, and providing basic emotional support. They also provide telephone follow-up. Community health workers can also be involved in programmatic roles. They can help patients navigate the healthcare system, making sure they follow up with the appointments and special visits that they need. They can help sensitize the local community to the needs of people with serious illnesses, those who need palliative care and have other significant health issues. And they can engage with the local community leaders to, again, seek wider, broader community support for the programs. You should also consider the local health authorities and how to initiate a collaboration with them. It's a good idea to follow the planning processes that are used by the healthcare system as you develop your program. And community organizations may help to establish a service which can later be integrated into the health service. It's also important to consider how to support patients' basic needs. You may want to consider referral of patients and families for food and other basic support items. And it's important to recognize that these patients and their families will be more vulnerable and marginalized than other members of their local community. So they will have difficulty perhaps accessing the services and supports that are available. Patients need to be supported for the cost of all the medications and equipment which is recommended, needed, or required for their palliative care. We also need to think about providing them with a long enough supply of medications to reduce the burden of travel for family members who may have to return to a hospital or clinic to collect the medication. And we know that refugee patients in community-based palliative care programs report their greatest needs to be money, medical care, pain relief, and food. So it's important that we address not only their medical and physical suffering needs, but also their needs for basic supports. Let's now discuss a case. This is a 6-year-old girl with facial swelling who was diagnosed with advanced cancer of her right eye. It was either a retinoblastoma or neuroblastoma. This is a child that we mentioned in the earlier video about hospital-based palliative care programs. Initially, the little girl was admitted to hospital and palliative care was started with the guidance of the telemedicine pediatric palliative care specialist. There was communication done with the family about the diagnosis and prognosis, and at that time, after learning this news, the family wanted to return home. Home care planning was started by achieving hospital-based symptom control and then making a plan for how the symptom control could be continued at home. The child had pain, so this was controlled with oral morphine at the dose shown there. She received liquid morphine, and they used 10 mg per ml injectable formulation so that the dose could be 0.25 mL given buccally. This reduced the need for her to swallow large volumes of medication. Also, the child did not have an NG tube placed as the parents were unable to maintain this at home, and the team established that given the child's advanced cancer, NG feeding would not improve her quality of life or prolong her life. The parents were provided with teaching about mouth care and how to feed the child for comfort in a safe position and with foods that she could tolerate. The parents were also provided with education about the importance of providing the pain medications regularly. It's important to train families to understand that they shouldn't wait until the symptoms are severe, as this makes it harder to get the symptoms under control, and the child will likely require more medication. After this teaching was done, she went home to her village where community health workers visited weekly. With each visit, they would call to the doctor and the nurse at the MSF hospital. Her condition slowly declined with each visit. After 2 weeks, the team found that she was eating less food and was sleeping most of the time. For the last week, there were daily visits from the community health workers. Morphine was given for pain in her face and her abdomen, as we'd mentioned before, 2.5 milligrams buccally every 4 hours. She also became agitated and restless, so the team started giving her lorazepam, 0.5 milligrams buccally, every 6 hours to help her rest. Of note, this medicine was prescribed by the general palliative care team from the hospital, and was explained that it would not cause her to die sooner, but would just make sure she was comfortable. The little girl died at home peacefully 3 weeks after discharge from hospital. Bereavement care was provided in the following ways. After the child died, the community health workers visited her home to support her family. Family members find these visits to be very supportive. They've grown used to the community health workers and the emotional support provided by them. Sometimes after the child dies, they lose this support, so it's important to continue some visits. Home care and hospital-based team members met to reflect on the care. Staff shared their experiences and how this case was quite difficult for them because she was a very young child. They were able to receive support from the other members of the team as they shared together. Additionally, the community and the local community health workers arranged an annual celebration of life, which honored those children and adults who had died over the past year in the community. Let's look at a second example of a 3-year-old boy with cerebral palsy and seizures. This little boy was discharged from hospital after a 1-month admission for aspiration pneumonia. The community-based team was then asked to provide monthly visits to follow up on how he was doing. Communication with his parents had been done about the diagnosis and prognosis. This was started in hospital and continued with the home-based team. The community health workers were able to assist with physiotherapy, medication counseling, and basic care and support for the family. Additional supports that were engaged by the team included a community physiotherapist who developed a stretching and positioning exercise program to help reduce his contractures, improve his range of motion, and reduce aspirations. The exercises were taught to the community health workers, and they helped the parents to understand and complete the exercises. Regular visits from the community health team also identified when he was getting sick so he could promptly start on treatment with antibiotics at home. Additionally, the team ensured that he had seizure medications provided free of charge and that he took these continuously and the treatment didn't lapse. This resulted in improved seizure control and, as a result, fewer episodes of aspiration pneumonia, and the child's condition improved. In summary, we've talked about how home-based palliative care uses a palliative care approach that's provided by community health workers with basic palliative care training. They take support from physicians and nurses in a hospital-based palliative care approach. The goals of such a program include continuing treatment plans for pain and other distressing physical symptoms, particularly with medication counseling and support, and making sure patients have access to the medication so they continue them. Recognizing and supporting the spiritual, psychological, and social needs of patients and their families, and this is done through regular visits to help the family feel the child is not being abandoned or forgotten. And lastly, the team can support home-based end-of-life care plans. We'd like to share a few additional resources with you, which can be used to help with palliative care planning. We have 3 guides from the WHO on planning and implementing palliative care. These are shown here with the links to access them. Here are some palliative care training resources that you may want to access. There's a palliative care training workbook for carers, which is at the link provided. This can be used to train volunteers, community health workers, and family caregivers. There are palliative care training videos that we've developed, and these are available on our YouTube channel. There's the e-learning modules on children's palliative care from the International Children's Palliative Care Network, which are available for free and are at the elearn.icpcn.org website. And these modules, after completion, you'll receive a certificate. And lastly, there's the Symptom Control Manual and some other free books which you can access through our Google Drive at the link that we've shown.